Good evening, everybody. I hope you can hear me right now. Anybody can raise his hand and tell me yes or no. Okay, perfect. So let's get going. Thank you, Dr. Neeraj. Thank you, Dr. Venkateshan. Let's get going, and we are going to talk about a very simple, basic topic of evaluation of right heart. When I was looking for right heart in a pericardium, I thought, let me take a first right heart, and then we'll take a right pericardium later on, because combining these two topics together would be a little difficult for all of us. So we are going to deal only with right heart and then finally. May I request everybody to please silent your mic, because all of you are an educated person. And whenever somebody disturbs, it becomes a lot of difficult for us to continue these sessions.
लेवल मशीन भी चलना है क्या?
So let's talk about right heart hemodynamics. To begin with, this is what we are looking forward. This is what we are looking forward in patients of right heart hemodynamics is we look at the RV-RA functions. We look at the RV systolic pressures. What do we look in RV systolic pressure is? Look, this RV and RA, they are much bigger than LV-LA. That's in apical four-chamber view. Look at a significant amount of tricuspid regurgitations. Look at over here in short axis view. Look how big the RV outlet is. And in proximal part and distal part is almost normal. The inlet part is reasonably okay. On the contrary, if you look at the interventricular septum, this septum is flattened during systole. So look at all these hemodynamics of RV-RA. We are going to talk about this particular issues. What we need to understand in this subset of population is we need to understand the following features. What is the definition of pulmonary hypertension? What are the RV structures and their hemodynamics? Does all method of evaluation of pH are complementary to each other or comparable to MRI and right heart catheterization? If somebody asks you today, what is the most important and most reliable method of assessing RV pressure is, take my word, the word of MRI and right heart catheterization will come close by. Whatever we do echocardiography is a good method, and especially three-dimensional echo is comparable with MRI and right heart catheter. Let's talk of a definition of pulmonary artery hypertension. It's defined as mean, not the peak. Mean pulmonary artery pressure more than 25 millimeters of mercury at rest and more than 30 millimeters of mercury after stress. And this requires a diagnosis of pulmonary vascular resistance more than 3 millimeters of mercury per liter per minute, that's a Wood's unit, and pulmonary capillary wedge pressure or LA mean pressure or LVEDP less than 15 millimeters of mercury. So what we have? We have two parts. One part is mean pulmonary artery pressure. Second part is pulmonary vascular resistance with left ventricular end diastolic pressure of less than 15 millimeters of mercury. And on the other hand, it is defined as increase in mean pulmonary artery pressure more than 25 millimeter at rest as assessed by right heart catheter. The question comes, what is a normal pulmonary artery pressure at rest for a normal subject? It is 14 plus minus 3 millimeters of mercury with an upper limit of about 20 millimeters of mercury. So anybody who has got less than 20 millimeters of mercury as the right heart pressure or mean pulmonary artery pressure is considered as normal. 20 to 24, that is 1 and 24, that is the clinical significance which is not really known about. Patient presenting with pulmonary artery pressure in this range should be carefully evaluated and followed because they are likely to develop pulmonary hypertension over a period of time. So what do? We have to follow them annually. And that's true, very true, when we are looking for certain conditions like people who have got a heritable pulmonary artery hypertension or connective tissue disorders. There, the importance goes up dramatically. So if I have to say in nutshell, mean pulmonary artery pressure less than 20 millimeters of mercury is considered as normal. 20 to 24, they are the subject of high-risk population. More than 25 is considered as pulmonary artery hypertension. Now, how do we look at this pulmonary artery hypertension? I'm going to dwell a few minutes on this. Before I go to pulmonary artery hypertension evaluations, we need to understand the classification of pulmonary artery hypertension. What is the classification of WHO as far as functional class is concerned? And I'm sure all of us understand this functional class is class 1, he can perform ordinary physical activity without symptoms. Class 2, he develops dyspnea or fatigue with ordinary activities, but he's comfortable at rest. Class 3 is marked limitation of activity, less than ordinary activity, that causes breathlessness or symptoms, but again comfortable at rest. And fourth one is when he cannot perform a regular activities and is dyspneic and at rest. Why we are talking of this WHO classification functional class for description is because these are the subject of population who will be coming to you regularly when we look for this pulmonary artery hypertension. Important thing is these people, they have this class 1, class 2, class 3 classification based on their limitation of activity. Now anybody can come up and ask me a question. What is an ordinary activity that causes symptoms in dyspnea? What do you mean by ordinary activity? Ordinary activities like going to toilet, bathroom, doing your routine work, cleaning your room, doing your clothes. That all comes in routine, ordinary activities. Now, there's one very important word in this particular phenomena, which is known as precapillary and postcapillary or mixed pulmonary hypertension. Well, all of us understand if I develop a pulmonary artery hypertension, my mean pulmonary artery pressure has got to be more than 25 millimeters of mercury. Then pulmonary capillary wedge pressure of less than 15 millimeters of mercury and pulmonary vascular resistance of more than 3 Wood's unit. Is that very clear? Nothing abnormal in this. Next important comes Post-capillary. Pre-capillary means pulmonary artery per se. Post-capillary means where secondary to left-sided patients. How do you differentiate a left-sided patient? We have taught about diastology. Diastology is when we have a grade 2 diastolic dysfunction, when my LA pressures are more than approximately 10 to 15 millimeters of mercury. That is grade 2 diastolic dysfunction, and which correlates very well with pulmonary capillary wedge patients. Then we have pulmonary vascular resistance less than 3 volts unit. So you may be finding a patient where mean pulmonary artery pressure is 25, pulmonary capillary wedge pressure of more than 15 millimeters of mercury, and Wood's unit is less than 3. And this is a classification which shows that the patient belongs to post-capillary pulmonary artery hypertension. Now, how do we say which is pre-capillary, which is post-capillary? Pre-capillary is patient of chronic obstructive lung disease. So they belong to this category of pulmonary artery hypertension. Heart failure with preserved ejection fraction, they belong to this category of pulmonary artery hypertension. And now we are seeing more and more people who are smokers, and on top of that, they have hypertension, diabetes, sleep apnea syndrome, obesity, hypothyroidism, and they have something like a features of combined post-capillary as well as pre-capillary. And what happens in those subset of population? Mean pulmonary artery pressure is more than 25. Pulmonary capillary wedge pressure is more than 15. Pulmonary vascular resistance is more than 3. So we have all the features of pre-capillary as well as post-capillary in this subset of populations. Now coming to classification, which was given in 2009, and it's very important classification to differentiate the kind of pulmonary hypertension we are having. And this classification has not changed ever since it was given, like almost 15 years down the line. What we look is grade 2 is heart failure with preserved ejection fraction, valvular lesions, cardiomyopathies, hypertension, diabetes. Group 3 is chronic obstructive lung diseases. All of us can understand anybody who is a chronic smoker develops a pulmonary artery hypertension, he belongs to group 3 lung conditions. Apart from 2 and 3, there are 3 more classifications there. Group 4 is very clear, chronic thromboembolic pulmonary artery hypertension. So if we look at group 2, we look at group 3, look at group 4. Group 2 is left-sided heart lesions producing pulmonary artery hypertension. Group 3 is people who have left side is normal, but they develop a pulmonary artery hypertension. And group 4 is a classical example of chronic thromboembolic pulmonary artery hypertension. Apart from something which belongs to group 1 and group 5, if you have an idiopathic, if you have a hereditary, if you have a drug-associated pulmonary artery hypertension, that belongs to group 1. And if you have a group 5, where again cause is unclear, multifactorial etiology, and especially the deposition diseases like CRF, storage disorder, sarcoidosis, myeloproliferative disorder, amyloidosis, they all belong to group 5 pulmonary artery hypertension. So whenever we talk of pulmonary artery hypertensions, by echocardiography, we try to label whether this patient belongs to post-capillary, that is group 2, pre-capillary, that is group 3, or a mix of these two. And we try to label why this person has got pulmonary artery hypertension. I'm not going to go to detail of this classifications. We can read, all of us can do in every way. Look, how does ECG makes a help, or it helps you in coming to certain conclusions? Well, all of us understand what is the most important pathological features of right side lesions in ECG. What we have a P pulmonale, tall P, almost more than 2 segment small squares, right axis deviation more than 110 degree, RVH, inverted T wave in lead V1 to V2, RV stain, RVBB, prolonged QTC. And this presence of prolonged QTC in the presence of pulmonary artery hypertension suggests significant disease. On the contrary, a patient presenting with post-capillary can have significant coronary artery disease, atrial fibrillation, and other factors, giving rise to abnormalities in ECG. I said the first thing in line is the most important diagnostic modality or a gold standard is cardiac MRI or right heart catheterization. Well, we cannot do a right heart catheterization virtually in every subject. We can't take them again. We can't do that in the midnight at 12 o'clock. So what do we do? And that's where the echocardiography is placed at the first test of choice whenever we suspect pulmonary artery hypertension. Not because it only estimates systolic pulmonary artery, because it can assess the sign of right ventricular dysfunction as well as left ventricular dysfunction to distinguish between category of grade 2, grade 3, and on top of that, it can tell you multifactorial etiology. What is the cause of this pulmonary artery hypertension is whether it belongs to cardiomyopathy, it belongs to valvular lesions, it belongs to heart failure with preserved ejection fraction, many of things. And on top of that, if that is normal, possibly it's related to right heart disease. Any of you can get up and ask me, look, why we are looking for this pulmonary artery hypertension? Look, it has got a certain prognostication values. What is the prognostic value or percentage of survival based on this etiology? Look, for a congenital heart disease, these people, they have a longevity of almost, percentage of survival is almost 80 to 90%. Postpartum, idiopathic, the line drops to almost 60%. Chronic thromboembolic diseases or HIV, we have a significant lower survival in these subsequent. So assessing first is pulmonary artery hypertension, then possibly its cause makes a lot of difference in doing a pulmonary artery hypertension. This is what work we did in 2011 at Europe Echo. We had approximately 12% of all cases having PH in Europe Healthcare. 70% of these lesions were belonging to left heart diseases. 20% belongs to a lung diseases. 4% was idiopathic, or in the sense we were not able to identify the cause. 0.6% was chronic thromboembolic phenomena, and 7 we again could not identify what was the cause of these subsequent. If you look at this grade 2, this is grade 3, this is grade 4, this is 1, and this is 5. Now, another very important thing is heart is not a straightforward as far as RV is concerned. Heart in RV has got 3 components. One is a tricuspid valve annulus, which is proximal to infundibulum, or what we call them as inlet. Then we have apex or apical tuberculation of RV, and then in outflow. So it's a sickle-shaped structure which forms a RV structures. So we cannot evaluate these structures in one go. I'm going to show you a couple of images in a time to come. So what we need an RV focused view as well as parasemic short axis view to look for inlet as well as outlet part along with tubercular portion of. Now let's start the evaluation as far as the right heart function is concerned. We do it by M mode and 2D echocardiography, that is qualitative. But quantitative is more important than qualitative. And what do we do? And quantitative is we look for a Doppler infections. This is one patient who has got an interventricular septum at the level of Plaque's window, mid-interventricular septum. And this is a cutoff where you see a uniform diastole, systole, uniform diastole, and systole. If you happen to compare this image, you find 2 beaks of systole in the interventricular septum. What exactly happened? This is the diastole. So the septum first is already bulging on this side. So it has to go back, come back again, and then contract to do a systolic contraction. And that's how these people present And I cannot say with you like you can assess in one day. It's not possible. So what do we do? Look at this picture. Look at this picture. This picture is pretty smooth, sickle shape contraction. This picture is not smooth. In fact, it has two contractions at the same time. These are qualitative, and this is an era of not a qualitative evolution. This is an era of quantitative evolutions. So what do we a quantitative evolution? Very simple four-chamber view. In this four-chamber view, this is inlet part, this is trabecular. And look at this four-chamber view very carefully. What does it tell you? LV is over here, LA is over here. RA is over here, RV is over here. Normally, RA pressures are less than LA pressures. Here, RA pressure is much more than LA pressure in the sense intra-atrial septum is bulging towards left-hand side. What does it mean by? Normal, we have an RA pressure of LA pressure of 8 to 10 millimeters of mercury. Here, the LA pressure is more than 10 millimeters of mercury, and normal RA pressure is only 5 millimeters of mercury. Look at the RV and LV. LV is bullet shape. RV is normally triangular shape. Now RV has become dilated. It has long lost its triangular shape completely, and a lot of tuberculation is seen in this RV. If I have to say this patient, I can only say that this RA pressure is more than LA pressure, at least more than 10 millimeters of mercury. And on top of that, RV is bigger as compared to LV. It could be because of a volume overload or it could be a pressure. Very interesting slide. If you happen to look at very carefully, this is parasolic short axis view at papillary muscles level. With every systolic contraction, this interventricular septum is bulging towards left ventricle. How it's bulging towards left ventricle is because RV pressure is more than LV pressure during systole. And this is what is known as systolic bulging during systole is suggestive of pressure overload rather than volume. So how do we differentiate pressure versus volume overload? Is dilatation, D-shaped ventricular during diastole, and further changes to sickle shape during systole, that is pressure overload. And if it remains D-shaped during diastole, nothing significant change happened during systole, it's volume overload. Now, what is volume overload? What is pressure overload? Volume overload is ASD, atrial septal defect. Pressure overload is pulmonary artery hypertension. Could be COPD, could be pulmonary embolism, whatever it is, it could be. So that's how we differentiate. Volume overload is presence during diastole, and when this interventricular septum bulges towards LV, this is known as pressure overload. Some people label this as eccentricity index. Well, I'm not that kind of a person who will say that we should not use it. But at the same time, how does it make a difference to calculate the eccentricity index, which is a follow-up of 1985? What does the eccentricity index tells you? It says measurements are made both in end diastole and end systole. In normal subject, the ratio of 2 would be equal to 1. So we measure this at one dimension, this is one dimension, and both of them should be almost equal. In patients with pressure volume overload, the end systolic ratio is approximately 1, while end diastolic ratios increase. So that's what it says. If this ratio becomes or D-shaped, and this further becomes more at the end of systole, this is pressure overload. And it's better to use this word. Looking at this particular slide again, look, every systolic contraction, this ratio, this is one ratio over here, this is length, which remains stable. This is 1 on the cross side, this is D2. D1 and D2, they are equal when there is no pressure, no volume. Over a period of time, this D1 remains the same. This D2 start becoming smaller and smaller, giving rise to more than 1 as a ratio. In systole, in diastole, it will be less, and with systole, it will be more during systole of eccentricity. Well, that is whatever we contribute to that is connecting to a qualitative evaluations. Now, ERA is not for qualitative evaluation. We say like we have given you about 5,000 rupees. But how do we show that there are 5,000 rupees only? And that's what we need is a quantitative evaluations. In quantitative evaluations, we need to look at these kind of factors. It may look a little longer, but I'm sure I'll show you one of these factors at a time so that you can remember them and do them over a period of time. One is RA pressure. And how do you look at RA pressure? This is how we used to look at when we were in medical college. Like put a hand behind the patient's shoulder, raise him to 45 degrees. One guy used to hold a scale on a vertical direction. One guy used to hold a scale where this pulse used to be on upper side and then draw a line. That was an RA pressure in centimeters. But in echocardiography, we don't look at an RA pressure with that particular phenomenon. We look at an RA pressure by doing a measurement during end expiration, inspiration, just distal to the hepatic vein. So here is a hepatic vein, here is a IVC, here is a RA. So we just put a line or we freeze the image in end expiration and measure from leading edge to trailing edge to leading edge, how much is my IVC sizes. Patient takes a deep inspiration and look at the how much smaller it has become. And that's how we measure our IVC size. And once we measure the IVC size, then we come to know what kind of an RA pressure is. Other people, what do they sometimes? They put an M-mode line across this hepatic vein to RA junctions. Just distal to it, they put an M-mode line starting from here. They put an M-mode line here. And with this M-mode line, they understand this is my end expiration and this is with the inspiration. So I can measure this distance in end expiration and virtually there is no distance left in inspiration. If it's less than 21 millimeter size, almost disappear. It means that we are having a RA pressure of 5 millimeters of mercury. So this is what the measurement what we do is during end expiration with inspiration. This is how the size reduces over a period of time. And if you look at this size, which is reduces over a period of time with inspiration, I have made this a graph very simple for all of you to remember. This is the color of our Indian flag. Less than 21 millimeter size, normal. More than 50% collapse, 5 millimeters of RF. Last week, the back pain case examination routine always 15 do the, he looked at the back. If the size is more than 21 millimeters of mercury, the collapse is less than 50%, then RA pressure is 15 millimeters of mercury. So remember this value, less than 21, more than 50%, normal 5. More than 21, less than 50%, it's 15. And anything between that is considered as 10 millimeters of mercury. Very simple, 20, forget about 21. 20, more than 50% collapse, RAP 5. More than 20, less than 50% collapse, RAP is 15 millimeters of mercury. And that's what is very useful. In cases where we found that IVC is not collapsing at all, like in this subject, more than 21 millimeters of mercury, this is not collapsing at all. We always try to do a sniff method. And all of us understand how to do a sniff method and then look for a collapsibility of these subset of populations to be sure that our RA pressure is 15 or more, or it could be a 10 millimeter, or it could be definitely it cannot be 5 millimeter, but it could be 10 millimeter in the sense the collapse could be more than 50%, not 15, so it becomes 10 millimeters of mercury. Now, this is most important thing of pulmonary artery hypertension. All of us has been doing this formula for a long, long time. What do? We go to 4-chamber view. We put a cursor line across the TR and drive a Doppler flow pattern. This Doppler flow pattern looks like this over here. Measure the peak velocity over here is 4.44 meters per second, contributing to almost 79 millimeters of mercury. Peak pulmonary artery pressure, but this is the TRZ is a RV systolic pressure. So what is the blood is pushing from RV to RA? So RA has got the inherent pressure which we decide from a IVC. So if this is a tricuspid regurgitation or RV systolic pressure, we add RAP right atrial pressure to develop the peak pulmonary artery. But peak pulmonary artery pressure does not give us an answer because we are not looking at peak pulmonary artery pressure, we are looking at mean pulmonary artery pressure. Second important thing is the most important part of second evaluation of this particular phenomena is we have to assess pulmonary artery pressure from 5 different windows. As we said for aortic, 6, the same thing is so for 5 different windows. Starting from parasol long axis view, no way, we cannot get a pulmonary TRZ velocity. We go to RV, RA inflow view. That's first one. Then we go to parasol short axis view at aorta. Then we go to apical four chamber view. Then we go to RV focused view, and finally the subcostal view. And mind my words, wherever the maximum TRZ velocity and gradient is, we say we saw a TRZ gradient as seen in this patient. This was seen in focused RVRA view with a gradient of 4.44 millimeters of mercury and a velocity of 4.44 with a gradient of 79 millimeters of mercury. And best seen in RVRA focused. That's very important because tomorrow if somebody does an echocardiography, he does not go to that window. Obviously, he'll underestimate or overestimate his pulmonary artery pressures. The next important thing happens once we do this pulmonary artery pressures, we come to a conclusion, look, my RV is contracting at such a fast, high pressure that is generating a gradient of almost 80 millimeters. So we develop or we drive peak pulmonary artery pressure. But how do we get mean pulmonary artery pressure? That is the most important thing. Because as I said, 21 to 24 is considered as to be observed. More than 25 is elevated. And that's what we have a temporary classification, which is like given arbitrarily. More than 25 to 35, mild. 36 to 45, moderate. More than 60, 46 is severe pulmonary artery. But how do we get mean pulmonary artery pressure? And that's what the formula is. Whatever you get a peak pulmonary artery pressure, like here is 79. So for the sake of easy, let's make it 80 plus RA pressure, that is 85. 85 into 0.6 plus 2.1, you will get a mean pulmonary artery pressure. And this mean pulmonary artery pressure, again, all 5 windows. And wherever you get the maximum, you say, I could drive my mean pulmonary artery pressure, which is a formula of peak pulmonary artery pressure into 0.6 plus 2.1. That gives you mean pulmonary artery pressure. And this mean pulmonary artery pressure will help you in telling whether my pulmonary artery pressures are raised or not raised. A catch over here. What is the catch over here is, if you look at this RV contraction, if my RV is not contracting properly or is hypokinetic, then I'll not be able to generate these gradients. The condition is the peak pulmonary artery pressure and mean pulmonary artery pressure, whatever we determine in the sense that my RV is contracting now. Is that clear? And that was the most important fundamental structures of calling as a mean pulmonary artery pressure. Now, moving on from a gradients to look for prognostication of these people of pulmonary artery. How do we do it? We look at the tricuspid valve closing and tricuspid valve opening time. Then we go to pulmonary artery ejection time. This is A, this is B. A minus B divided by B will give you a Doppler phenomena of pulmonary artery hypertension time. Sorry, right-sided myocardial performance index. So here is paracetamol short axis view at aorta. We went on to do a pulmonary artery acceleration from the beginning to end. This is known as pulmonary artery acceleration, ejection time. Then we got tricuspid closing and opening time from apical four-chamber view. TVCO is 340. Pulmonary artery ejection time is 170. 340 divided by 170, that becomes 170. 170 divided by 170 would be 1. Higher of this pulmonary, the right side myocardial performance index, poor is a prognosis because anything more than zero point 0.4 is considered as a significantly high risk of developing comorbid condition, significant high risk of developing a mortality. Normal is zero point 0.4. And if you happen to see this right-sided myocardial performance index, which is a very simple formula of looking at the tricuspid valve closing, and don't look at this word of mitral valve. Look at the tricuspid valve closing and tricuspid valve opening time, divide by pulmonary ejection time in RVOT, and A minus B divided by B will give you a myocardial performance index of the right side. Normal is 40. Anything more than 40 is considered as. So we learned about RA. We learned about peak pulmonary artery pressure. We derived mean pulmonary artery pressure. We looked at a peak. We did not look at this peak PR gradient or endoscopic gradient. We looked at the right side myocardial performance index. And now comes the most important thing is pulmonary vascular resistance, how to calculate. It's a very simple thing of calculating a pulmonary vascular resistance. Everybody of us is afraid of doing this particular phenomenon. What do we need? We have a patient of pulmonary artery disease. We look at a TR jet velocity. So all of us has got a TR jet velocity. So look at this patient who has got a TR jet velocity of almost 4 meters per second. So we look at TR jet velocity, and this TR jet velocity 10 into TR jet velocity divided by RVOT VTI. So what we need a four-chamber view focused RVRA view to look at TR jet velocity, and then we look at RVOT VTI. 10 into TR jet velocity divided by RVOT VTI will give us a value of Wood's unit. Here is the example. The velocity is 2.4 meters per second. VTI is 15.5. 10 into 2.4 meters per second divided by 15.5. This is 10 into 0.16, which is 1.66 Wood's unit, which is considered to be normal. On the contrary, here the TR jet velocity is almost 3 meters per second. Velocity time integral from RVOT is 6 centimeter. 10 into 2.9 divided by 6, that is 10 into 0.48. This is 4.8 Wood's units. And that's how we decide about this pulmonary vascular resistance non-visibly by echo. Next important thing is, what do we look at the QP-QS ratio? And I'm sure I don't have to tell you how do you look for a QS ratio, because we have taught this QS ratio number of times. What is QS ratio? What does it mean by? We are looking at the stroke volume at LVOT. And how do we get the stroke volume at LVOT? Is we get the stroke volume by LVOT area into LVOT VTI. Is that correct? Or something wrong with it? So we get LVOT area into LVOT VTI. That is stroke volume at systemic level. That is QS. On the contrary, if I got to pulmonic level, what do I need to look at it? We go to paracetamol short axis view at aorta, go to RVOT, calculate the RVOT diameter, get an area, multiply by VTI, you will get what? You will get all the reasons of stroke volume at the level of pulmonic artery. So stroke volume at LVOT and stroke volume at RVOT should be almost same in absence of any shunt and other things. And that's what we calculate in right side lesions. Now example comes, suppose I've got a patient of ASD. So what will happen to the patient of ASD? His stroke volume at the level of pulmonary artery or RVOT would be much more than at LVOT. Similarly, for VSD. And you must have read during your training period, during MBBS and MD, whenever the stroke volume, the QPQS ratio is more than 2:1, it means 2 times the blood is flowing or 2 times the stroke volume at pulmonic levels at 1 time of the stroke volume at systemic levels means the shunt is significant. But how do we calculate? Similarly, like we calculate a stroke volume at LVOT, stroke volume at RVOT, that is give us a quantification of QPQS ratio. Now, another way of calculating peak pulmonary artery pressure across shunts. How do we calculate peak pulmonary artery pressure at shunts? Is the most common example is VSD. And this is the case of parasol long axis view. Here is the aorta, here is the LA, here is the LV, and you can see a mid-muscular outlet VSD over here. Why do you see outlet? Because we could see an opening of aorta over here. If I put a line across this outlet, this VSD, what I do get? I get a gradient across this VSD. And look at the velocity over here is 4.44 meters per second. Let's assume that this velocity is 4 meters per second. So it means the gradient between LV and RV is 4 into 4 into 4, 4V square, that is 64 millimeters of mercury. Now RV has got certain gradients. And how do we calculate the RV gradients? We calculate the RV gradient by looking at TR jet velocity, that is RV systolic pressure, which pushes the blood into RA. So normally RV velocity, TR jet velocity is approximately less than 3 meters per second. 3 into 3 into 4, 36. 64 into 36 plus RA pressure of 5, the systolic blood pressure would be 105. So if I get a gradient, higher the gradient is, the less is the chances of having a pulmonary artery hypertension. Finally, we have quantitative method to assess the RV systolic function. And at your level, we look at only one thing, which is known as TAPS. What is TAPS is, we go to a 4-chamber view, put a cut section across the tricuspid annulus, how much this tricuspid annulus move during systolic, which is known as tricuspid annulus plane systolic excursion. Anything more than less than 17.5 is considered as RV systolic dysfunction. Very simple method. And take my word, though the slide is 2015, even in this era of 2024, this is the most robust and reproducible method of assessing RV systolic functions. Another way of looking RV systolic function is by putting a Doppler or tissue Doppler imaging at the tricuspid annulus and measuring this S wave. And this S wave has to be more than 9.5 centimeters to consider this as normal. If you put this RV systolic function by TAPSE or you put by RV free wall TDI, then the answer is the TAPSE is more consistent than RV free wall TDI. Last, not the least, I'm just going to repeat it again. We have taught this already. What we look is a linear dimensions for inflow of RV, because that's what I said in the beginning. RV is a sickle shaped structure. What we look at a tricuspid inflow and trabecular patterns. So we look for inflow at the level of annulus, long axis, and the short axis. And similarly, we look at the RVOT proximal in Black's view and RVOT proximal again in parasol short axis view at aorta. And this is what RVOT distal. And this is what is used for calculating the pulmonic pressures in patients to calculate QP ratio, QP volume, stroke volume across RVOT. So what do? We measure from one hinge point to another hinge point. put a sample volume across this RVOT, and we get an area from this multiplied by some RVOT VTI. What we'll get? We'll get a stroke volume at RVOT levels. We can remember these figures like RVOT at Planck's window is up to 30, RVOT proximal diameter is 31.25, and distal is almost 26. That's what we need to remember. So what I do is whenever I see is I remember like whether I'm not sure whether you can remember, I say 25, then 30, sorry, then 35, and this is 25. So we remember 25, 35, 25. And that's how it is easy to remember the outflow dimensions. Another important thing for revision is we look at RV free wall thickness at the level of tricuspid valve where it opens up. That's somewhere in the middle of RV free wall. And measuring from this RV free wall, this should be less than 4 millimeters, less than 5 millimeter in size, and diastolic, not systolic. RA size, we look at the RA size in long axis and short axis. And if we draw this area, we develop some RA volumes. Area into length will develop the volumes of this. Why these things are important? These things become very important when we are looking at whether the structure is dilated or not. And whenever the structures are dilated, take my words, that really makes a lot of difference for finding out what is the reason of this dilatations. As I said earlier, RV is a sickle shaped structure. We cannot calculate its ejection fraction by two dimensions. So what we do, we look at a fractional area change. We go to end diastole, trace the area as we do in LV. Then we go to systole, then trace the area as we go in LV dimensions, LV size. So area 1, that is diastole minus area 2 divided by 100 will give you a percentage of change in fractional area change. So area 1 minus area 2 divided by area 1 into 100 will give fractional area change. Anything less than 35 is considered as abnormal. RV diastolic parameters is sometimes what is very, very useful. But at your level, just remember as we remember in LV size, if you happen to find an EA ratio more than 2, like tall E, small a, then think possibly we are dealing with raised right ventricular end diastole. This is one of the methods. Otherwise, how do we look at raised RV, right ventricular end diastole patients? Just looking at the RA itself will give rise to a very good value of looking at a raised right ventricular end diastole patient. Another thing is we can look at an E to E prime ratio at the level of RV free wall. If it's more than 6, it means RA pressure or right ventricular end diastole pressures are elevated. In summary, this is what we look at it, and I'm sure many of you will feel very abnormal looking at these subset of investigations. Thou have cut down my slides significantly just to make it for basic. And that's what I always say. Oh, so many methods, what to do in this session. How do we really go about this method? Do they correlate well with right heart catheterization or MRI? Are these methods are complementary to each other? Well, I always say that whenever you look at this method, which is published in this Journal of American Society of Echocardiography, and this is where pH of 20 and 20 with the chronic thromboembolic phenomena, they correlated well with cardiac MRI and heart failure, right heart catheterizations. So I'll stop over here and would like to take your questions one by one. And I'm sure you'll have so many questions on this particular phenomenon of right heart function, gradients, and RA pressure evaluations. So I'll request one by one to please raise your hand so that I can ask you, I can answer your questions gradually. Now, first I'll ask Dr. Rajesh Tiwari. And Dr. Rajesh Tiwari, please go ahead and ask your question.
Sir, good evening. Sir, can you please repeat how to evaluate mean pulmonary artery pressure?
Rajesh, very simple way of
Sir,
looking at mean pulmonary artery pressure is we calculate TRZ gradient. Suppose a TRZ gradient in apical four chamber gives 4 meter per second. Then we add
yes,
RV
sir.
pressure to it. That is 4 into 4 into 4 is RV systolic pressure plus 4
Yes,
of RA pressure. So 64 into 4 is 68. For calculation
yes.
purpose, let's make it 70. 70 into 0.6 plus 2.1 would be mean pulmonary artery. So we drive mean pulmonary artery pressure indirectly. We are not driving it directly.
Okay, okay. जी sir.
Next is Dr. Mahananda Mahatre.
Hello.
Go ahead.
Sir, while calculating RIMP, you explain the method by the pulse wave Doppler. Another method they mention in the book, that is by the TVI. Should we go for that method or should we stick to this pulse wave method only?
If you belong to level 1, we start talking of a Doppler method. If you belong to
Okay.
level 2, we start talking of a TDI method. If you are at
Okay, sir.
level 2 levels, please go ahead with TDI method because that is more accurate, because in that method you are looking at both systole
Okay.
and diastole at the same time.
And sir, that eccentric phenomena, explain again on that video. Till
Eccentric
confused.
phenomena means what?
Eccentric index.
Eccentricity index.
Eccentricities, septum motion and
This is what eccentricity index is. Just think,
yes.
like, instead of mugging it up, think the rationale of it. Normally, what exactly happens? This is D2 dimension, this is D1 dimensions, correct?
Okay.
Normally, in a person, this D1 dimensions and D2 dimensions are almost the same. Like D2 divided by D1 is 1.
So not understood. Show on the echo image.
Echo image is seen over there. Can't you see the echo image?
No, can't see.
I'll share it again. Can you see the echo image now?
No, still not able to see.
You can't see the echo image? Nobody can
No,
see?
no, sir. Not able to see. I'm not able to see.
Schematic is seen, sir. Echo image is not seen. You are shown the schematic.
No, it's a diagram which is shown over there. Do you read that word eccentricity index for right ventricular overload?
Yes, sir.
So that is what I'm trying to show you. That diagram I'm trying to show you.
Okay, sir.
Can you see this?
Yes.
Yes, sir.
I can see
Diagram
that.
is seen.
I'm talking of a diagram.
Yes, diagram we are able to see.
Diagram is seen. So
Yes.
in this diagram, this is the D2 dimension, this is D1 dimensions. In normal subjects, D2 dimensions and D1 dimensions would be same. The ratio would be 1.
Okay.
Now think when RV becomes bigger in size because of a volume or pressure overload, this D1 dimensions become smaller. Correct?
Okay.
So
Yes.
suppose D2 is 1 centimeter and D1 is 0.8. So ratio will be 1 divided by 0.8. That is more than 1.
Okay.
Now think of this phenomena during diastole and systole. If during diastole is 1.2 and it becomes 1.5 during this systole, it means
Okay.
it's a pressure overload. When
Okay.
RV has got a more pressure than LV, during RV-LV systolic contraction, this interventricular septum will bulge further during systole. Now let's go back to my picture.
Yes.
In this picture, if you look carefully, what do we see? With every systolic contraction, this septum is bulging towards LV.
Okay.
Is that clear or not?
Yes, sir. Clear now.
So this is what we are looking for.
Yes, got it, sir. T1, T2.
So if you look forward for this kind of phenomena, and best answer is, if you really want to be sure about it, put a cursor line across it
Okay.
in M mode. Then scroll your ECG from diastole to systole, systole to diastole. If this segment goes down further, it means we are dealing with pressure.
Yes, sir.
Clear?
Got it. Yes, sir. Yes. Understood.
Dr. Vandana Kumari.
Hello. Good evening, sir.
Good
How to
evening.
calculate the pulmonary artery pressure around the shunt?
Pulmonary artery pressure.
Around the shunt, जो भी थोड़ी देर पहले सर दिखाए थे VS in VSG.
Pulmonary artery pressure around the shunt, correct?
Yes, sir.
So calculating a pulmonary artery pressure around the shunt is not a difficult job. Like what we look at, I'm going to show the picture again. Can you see my images?
No, sir. Yes, sir.
It takes time because it has
Yes,
to go
sir.
to America, come back to India, then get distributed
Yes,
to the various states of India.
yes.
Okay. So how do we look for pulmonary artery pressure across the shunts? So let me get back that slide. So this is what we look for pulmonary artery pressure across the shunt. Now, this is my LV, this is my RV, correct? LV is pushing blood into the RV through the shunt. And this shunt shows a velocity gradient of 4 meters per second. If I use Bernoulli equations, it is showing 64 millimeters of gradient between LV and RV. Is that clear or not clear?
Yes, sir.
Dr. Vandana, you have to respond faster.
Yes, sir. Yes, sir.
It is clear. So now, as I said, RV has got some inherent pressure.
Yes, sir.
So how do you derive my RV systolic pressure? How do you know what is my RV systolic pressure? By looking at a TR jet velocity.
Yes, sir. Normally.
Normally, suppose my
Yes,
TR
sir.
jet velocity is 2 meters per second. So what would be my RV systolic pressure?
Velocity 4 into velocity square.
Then what is the value?
16.
Now the gradient is 64. This is 16. So 64 plus 16 would be what? 80 millimeters of mercury.
Yes, sir.
But RV is pushing blood into RA also. So RA has got also significant pressure, like 5.
Yes, sir.
So RV systolic pressure would be 16. Our pulmonary artery pressure would be 16 plus 5, that is 21. 64 plus 21 would be my LV systolic pressures. Clear?
Yes, sir.
Normally, what pressure do we expect between LV and RV? What is the normal
Between
systolic pressure?
in LV 120 systolic pressure.
120 millimeters of systolic pressure. What is
Yes.
normal RV systolic pressure?
Around 14 to 20.
20 millimeters of mercury or
20.
25 millimeters
Yes.
of mercury. So I can presume as 20. This is 120. The difference between RV LV and RV systolic pressure would be 100 millimeters of mercury.
Yes, sir.
Correct?
Yes,
Now,
sir.
if it's 100 millimeters of mercury difference is there and the gradient is only 64, what would be the pulmonary artery pressure?
Mm,
100 minus 36.
Yes, sir.
100 minus 64. So that will be my RV systolic. So we can indirectly drive PR jet velocity or peak pulmonary artery pressure by these shunts.
Okay. Okay. Thank you, sir.
Did you understand it?
Yeah, thank you, sir. Okay.
Sir, explain the last step again.
Did you understand it?
Sir, please explain the last step again.
No, no. Wait a minute. Wait a minute. She said, yes, sir. So I said, did you understand it? Dr. Vandana Kumar.
Completely not, sir, but
That's why did you say yes?
again we here and
If you would have said yes, I would have understood. I would have told you, repeat. What did I say? Okay, let's go back again. It's a very good method of assessing pulmonary artery pressures. Normal by LV systolic pressure is 120 millimeters of mercury. How do I get my LV systolic pressure? By taking a systolic blood pressure of the right arm. That is LV systolic pressure in the absence of any aortic stenosis. Clear? Whatever the systolic pressure I measure by arm is my LV systolic pressure. Now I take a gradient across this shunt. 120 and 64. 120 minus 64 will be the what value?
56.
56. So my peak pulmonary artery pressure is 120 minus 64. That is 56 millimeters of mercury. If I convert this peak pulmonary artery pressure to mean, so what would be the mean?
oh, 0.6 into
0.5,
pulmonary.
56 into 0.6 add 2.1. So take a calculator. Dr. Vandana, do you calculate, count your money or your husband counts your money? Your husband,
Yes.
35.7.
35.7. So it is moderate pulmonary artery hypertension. Are we
Yes.
clear or not?
Yes, sir. This time is clear.
Now you are clear. Now tell me, if you are clear, in this patient, what should be the shunt so as to call it as no pulmonary artery hypertension? Dr. Vandana is going to tell me this answer because she is going to count the money from tomorrow instead of her husband.
Yes, sir. Question again, sir.
The question is, what should be the gradient across the shunt to call it as there is no pulmonary artery hypertension?
Gradient is no, sir.
No? Come on. Anybody would like to raise their hand?
100, sir, instead of 64.
You have to raise your hand. I don't know who's talking about. I can't see the person who's talking about. Ananda Matre was talking about.
I was Dr. Jannavi, sir.
Janvi was talking about. So Janvi, what is the gradient did you say?
It should be equal to that of what LV pressure
It
normally.
cannot be equal. It should be close to 100. It cannot be 120 and 120. If 100 is a gradient, then 20 millimeters of a pulmonary artery pressures. Look, first thing I told you in the beginning is normal pulmonary artery pressure is what? Mean pulmonary artery pressure is less than 20 millimeters of mercury. Because blood has to be pushed into the lungs. How can you say the pulmonary artery pressure is 0? Got it? So it is, if it's
Yes.
100, then we say that possibly there is no pulmonary artery hypertension, because 120 minus 100 would be only 20. And if I drive this 20 into 0.6 plus add 2.1, 20 into 0.6 would be 12, add 2.1 is 14.1 mean pulmonary artery. Are we clear or not?
Yes, sir.
The length of answer tells you no. All right, go back and read. We'll discuss this next time. Next questions. Any other questions? All right, so everybody's sleeping or everybody's awake? So let me go to Dr. Humaira Akhtar. Humaira, can you unmute yourself?
Hello, sir.
Good morning.
Good morning, sir.
Tell me, what is the normal pulmonary artery pressures? Mean
Sir,
pulmonary artery.
less than 25. 10 to 25, 15 to 25, sir.
हमारा we have a saying in Hindi, सारी रात रामायण पढ़ी सुबह पूछा सीता किसका बाप था. Dr. Anardeep Wonder, Aninderdeep Wonder. Dr. Wonder, can you unmute
Hello.
yourself? What is
Good
the
evening, sir.
normal mean pulmonary artery pressures?
Sir, 25.
Normal. I told you the day for the first one. Let's talk to Dr. Arif.
Yes, sir. Up to 25, sir. 25 millimeter mercury.
Don't follow girls, man. Dr. Atindra Narayan.
Yes, sir.
Atindra
Sir,
Narayan, what is the mean pulmonary artery pressure?
the main pulmonary artery pressure normally is less than 20. I feel.
Correct. I only thought you are the only one who's correct, and you are correct. Mean pulmonary artery pressure is less than 20 millimeters of mercury. More than 25 is abnormal, and we happen to find between 21 to 24. We consider that pulmonary artery pressure as a watchful pressure in case of a patient has got a history of hereditary pulmonary artery hypertension or some other cause, idiopathic. The question is not mean pulmonary artery pressure is 25. The day it crosses 25, it's already elevated. So mean is 20 millimeters. Okay. Now let me show how many people are sleeping right now. Dr. Amandeep Dhanju. Amandeep ji, good morning. Look, Dr. Amandeep Dhanju has connected and he's disappeared. Shall we call his name again once more? Dr. Amandeep Dhanju. So that's not good. All right. So let me write out his name. I'll put in a word set. Dr. Amandeep Dhanju. Absent at 10:45 p.m. All right. Dr. Chandrika Naik. Dr. Chandrika. Are you there, Dr. Chandrika?
Yes, sir.
Good morning. Very good. Dr. Chandrika, we have got a pressure of 20 millimeters of mercury is a mean pressure. What would be the peak pulmonary artery pressure if my mean pulmonary artery pressure is 20?
So we have to calculate it with the formula.
Tell me, what formula?
0.6 into mean pulmonary artery plus 2.1.
No, my question is reverse. I said my mean pulmonary artery pressure is 20. What would be my peak pulmonary artery pressure?
So I don't know properly.
Okay. You said you calculate peak to mean, correct?
Yes.
So can't we do a revert?
We can.
Do it.
So can you help me?
Oh, I can do that. I am looking forward for Dr. Muruganam. Dr. Muruga
Yes,
Nandam.
sir. Yes,
Dr.
sir. Good evening, sir.
Muruganandam, please help me
Yes,
out
sir.
because I always feel the South Indian brain is much better than the masculine North Indian brain.
Sir, I'm also in the same confusion, sir. I don't know how to make it the reverse, sir.
Oh my God, I thought you had the best brain in the world, you know.
Sir,
Okay, let's go to North India again. Sukhminder Singh. Dr. Sukhminder, are you there? Dr. Sukhminder. Dr. Sukhminder Singh. This is not good. So I'll have to move on to across India. Let's see who can do it across India. Dr. Pratap Paul. Dr. Pratap Paul. Okay, anybody would like to answer this question? Can raise his hand?
30. Sir, 30.
Approximately 3, sir.
Arif.
30, sir.
29.8.
Wait a minute.
29.8.
29.8.
29.8. How did you calculate it?
We
20
subtracted 2.1.
20
added
mean
it from
pressure
0.6.
minus 2.1
Huh.
divided by 0.6.
0.6.
Yes, sir.
Okay. So you said 30, correct?
Yes, sir.
Yes, sir.
Around, yes, sir.
Around 30. So what would be the TRZ gradient now? To call it as 30. You said peak pulmonary artery pressure is 30, correct? So what would be the TRZ gradient in this subset of population? 30 minus 5, that is RA pressure is, it becomes TRZ gradient would be 25. And if I have to drive a TRZ gradient of 25, the velocity should be more than 2.5 meters per second. 2.5 into 2.5, 6.25 multiplied by 4 would be 25. So 20 millimeters of mercury pressure means my TRZ velocity is only 2.5. Now my TRZ velocity becomes 2.8. So what would be my peak pulmonary artery pressure?
So 31.36.
31.36. That is TRZ gradient. Correct?
Yes, sir.
Now add RA pressure to it. 5. It will be 36.
36.6, 36.
36.36.
Yes.
Multiplied by 0.6.
34.36.
Oh, no.
36.
That's what you did a mistake. 36 multiplied by 0.6. That will be 21.6. Add 2.1. It'll be 23.7.
9. Yes.
23.7. 23.7. Correct?
Yes.
23.7 means we are in a range of suspicion of pulmonary artery hypertension. Got it? Any doubt?
Yes, sir.
So if you happen to get a velocity of 2.8 meter per second, your ear should start ringing that possibly this patient could be a case of pulmonary artery hypertension. Got it?
Yes, sir.
And that what was the important take-home message is, look, I cannot calculate pulmonary artery hypertension in everybody. I need to have a one value which gives me an idea. Look, it is 2.8 or more. I should start thinking of pulmonary artery hypertension. Suppose it becomes 3. 3 into 3 into 4. 36 plus 5, 41. 40 into 0.6, 24. It becomes 26.1 mean pulmonary artery pressure. So the margin is very small, 2.8 to 3. So if you happen to see a gradient, a velocity, TR-jet velocity of 2.8 meter per second, your ear should start ringing that possibly this patient has got a mean pulmonary artery pressure of close to 23, 24 millimeters of mercury. And if it's 3, definitely that patient is in mean pulmonary artery pressure of more than 25 millimeters of mercury. Clear or not clear?
Yes, sir.
Yes,
This
sir.
time.
One more important thing when we talk of pulmonary artery hypertension. Let me just show you that slide. It's a very important phenomenon and we always overestimate our pulmonary artery hypertension. Look inside. The peak is over here and you can see a peak over here also. Look, the peak is over here. Correct? And we do have these kind of extra markers. So we have to measure in a person. I call this person as a bearded person. We have to measure the pressure at the level of chin, not at the level of beard. Did you understand my point or not?
Yes, sir.
So we should look at a parabolic image or look at the parabolic signals of the Doppler signals of the TR-jet gradient. This image is over, like the gains are very high. So reduce this gain to clear up your this parabolic image and then measure the peak. Otherwise, you are always going to overestimate your TR-jet gradients. Clear?
Yes, sir.
Perfect. Dr. Mahananda Matre, your question.
Yes, sir. Usually, sir, while doing 2D echo, I get TAPSE free, RV free wall TDI easily. TR-jet, whenever it is severe, I get it, but normal small TR-jet, I don't get only.
Matre, you have to do in all. Look, I don't say do it in every patient, but wherever you suspect a patient of COPD or right-sided cardiomyopathies or valvular lesions, use all 5 windows which I've told you. Right, starting from, we go to plaques, we go to RVRF inflow view, parasol short axis view at aorta, then we go to 4-chamber, focused RVRF view, and subcostal view. Now look at this.
Where severe is expected, I get it. But as you say, in every patient, we should have a normal TR-jet. That I don't get it.
If you don't get a TR-jet, normal TR-jet, in normal subject, it means you are hungry. You don't want to look for a TR-jet.
Yes, sir. Maybe tired.
Tired or hungry?
Yes, sir. I have to spend more time.
Correct.
What
One
about
more,
that
one
eccentric?
more, wait a minute. One more question for Dr. Mahatre. Dr. Mahatre, tell me in which window you will get the maximum TR-jet in this patient?
In this patient. Focused RV?
I've given you enough hint. Look at the direction of this TR-jet.
Eccentric it is.
Eccentric at what level? Where the tear jet is hugging along?
It is coming from up.
No, it's going towards which side? Intra-atrial septum. If
Yes.
this TR jet is going through RA free wall, then this will be the best window to calculate TR jet gradient.
Fourth chamber.
Now your cursor is along with this line, so you are not able to see this Doppler spectrum pattern. Correct?
Okay.
So
Okay.
that is the one reason why you're not able to see a TR jet gradients properly.
Okay.
Which is the window among 5 of them where you can get this window the best way? You can align your beam according to interatrial septum.
Short axis.
Now,
Subcostal then.
subcostal.
Yes.
Once you align your beam in subcostal, rotate this image. I can't rotate it by my hands, but sure, if you rotate this image in this subcostal window, the beam would be coming from here and it will align properly across this tear.
Yes, maybe sir, this is the mistake. I'm not aligning the
That's why
TRJ.
I said, that's why I asked you this question. That is
Yes.
the reason why I asked you this question.
Yes, sir.
And once you do it, believe my words, you will get excellent Doppler readings.
I'll try. Definitely.
Okay. Let's move on to Dr. Naveen. Naveen, go ahead.
Sir, good evening, sir. Sir, can you show an image with AST with volume overload and then later getting converted into a uh, pressure overload?
Okay,
AST patient.
let me try. I'll have to stop sharing these slides. I'll have to dig out my images. So you'll have to wait for a few seconds.
Yes, sir, please.
No, Naveen, I don't have one image right like now. I just jot it down and I'll send you across. Image of volume overload, pressure overload I have shown you already. Wait a minute, one more place I can try. There's one more place where I can try this images. I hope I have got a live images recorded. So give me 1 minute time. In fact, today only I have recorded large ASD today with volume overloaded conditions. Sorry, we don't have it, right? But I'll post it tomorrow. I have jotted down. I'll post it tomorrow.
Okay, sir. Thank you.
So, anybody else? Some question or before we close it down today? So we dealt with RV function today, RV systolic pressure, RV functions, and next week I'll possibly on a Friday, I would like to take on pericardium. So meanwhile, any questions you have, tomorrow I'll post the ASD volume overload and pressure overload again together to see both the differences together. So let me say you good night, stay safe, see you on Friday, 9:15, 9:30 p.m. I think that's the most ideal time for all of you to deliver another talk on pericardium in a very simple formation. How do we look at pericardial effusion? How do we look for pericardial tamponade? How do we look for effusive constrictive pericarditis? And how do we look for constrictive pericarditis? And few silent features, how to differentiate constrictive pericarditis from restrictive cardiomyopathy. And that's what we are aiming for coming Friday around 9:15 to 9:30. We'll start approximately at 9:30 p.m. for a class of about 1 to 1.5. With these few words, stay safe, good night, Shabba Khair. See you on Friday at 9:30 p.m. Bye-bye.
Good night, sir.
Thank you,
night.
sir. Good night, sir.
Thank you, sir.
Good night, sir.